support and survivorship. Ricky Fairley, who is the CEO of Touch, the Black Breast Cancer Alliance, and champion for the declaration that Black breast cancer is a different disease. And Roberta, aka Bobby Albany, CEO of Cancer in the Know, Chrysalis coach, patient advocate, and educator, ensuring no one faces breast cancer uninformed or unsupported. All right, so let's dive into it. Thank you all for being here. So, to start us off, when we talk about breast cancer in Black women, what major inequities are still most misunderstood or overlooked by the healthcare system and the public? Um, I would say, Dr. Mo, can we start with you? Oh, you're still muted.
Got it. Was the question about barriers that impact Black women? I'm sorry, what was the question?
Yes, when we talk about breast cancer in Black women, what major inequities are still most misunderstood or overlooked by the healthcare system and public?
Oh boy, so many. I think that I know it's a loaded question, and it ties into I'll just pick one area, right? And I think major inequities really look like inequities across the spectrum between screening, diagnosis, treatment, survivorship, trial enrollment. But what I see as a barrier and inequity is I'm seeing bias in a different way. Where there is a bias towards accelerated research and de-escalation and more precision tools for early stage breast cancer, right? More funding. We're putting a lot of lipstick on a pig for early stage disease where we're optimizing that rather than locally advanced or metastatic disease. And that's great, but only 54% of breast cancer in Black women is diagnosed at an early stage, which means that there's a whole category of research, of resources, of information that needs to be shared and disseminated around advanced disease. And I see that there's barriers and disparity there that's baked into our desire to advance the science for early stage disease. I think there's barriers in financial resources and navigation and inequities that are there that really don't just affect the patient and their ecosystem, but their ability to afford treatment, to adhere to treatment, to engage in things like trials. So I would say that there are many and that they are structural and systemic, as you mentioned. And we really have to look at the systems that are in place to try to figure out how to dismantle them.
Bobby?
Oh,
Oh, I'm sorry. Go ahead, Ricky.
it's okay. The science, I mean, we now have burgeoning data that validates that a Black breast cancer cell looks different from a white one. The research is coming out more and more every day. And we basically have been excluded from clinical trials for all of the treatments that we have available to us. And so our mortality rates reflect the fact that the treatments aren't working as effectively as they are for white women. And we're getting it younger, and we're getting it triple negative at 3 times the rate of white women. And the biology is clear now that our cells are different, our breast cancer is different, and until we treat it differently and have treatments that work and have tested on our bodies, we're going to keep dying.
Bobby?
Pretty much the same with everyone is saying. It is a loaded question. So a lot of it are people not getting just regular standard of care, and that's a problem. Being misdiagnosed or tell them to go and come back, the wait and watch situation. So yeah.
Tia?
Yeah, Jamil, that's a great question, and I echo what everyone is saying. I'm not a particular fan of the word overlooked. I think the word is so soft and it removes the real problems. And so for me, it's structural failures. And I think we need to call it out. It's a
Mm.
structural failure. When we look at women who have the worst survival outcomes, we have the highest financial toxicity, all the things that we said here, lower access to survivorship care, our pain is minimized. These things aren't overlooked, right? They're structural failures that to me have been tolerated And when we tolerate these things, these inequities become normalized. So for me, the structural failures are not prioritizing the health and the needs of Black women, both before diagnosis, during diagnosis, and even after diagnosis.
Dr. Guerra?
I echo everything that has been said. But however, I would dare to say that there's segregation in healthcare, and healthcare is what I do. And that's been shown through data. There was an interesting article about a year ago that looked at hospitals that provide care to Black individuals, hospitals that predominantly provide care to Latino individuals, and those two were compared with all the other hospitals. And there's about 430 of those that provide care to Black individuals. And they showed how the authors was Patty Gans at UCLA. They showed that if you go to one of those Black or brown hospitals, you are going to be less likely to get cutting edge everything, whether that's cancer surgeons that specialize in breast cancer, whether that's MRIs, whether that's PET scans, even pain consultations and palliative care, you are going to get less of that. And so I think that Tia said it best. There are structural issues here that we have to figure out how to correct for, overcome. Maybe we can't. Maybe we just have to build a new system. But I think that is very troubling, that where you go for cancer care determines whether you get guideline concordant care.
Absolutely. Now,
And Dr. Guerrero, may I ask the question? Did that juxtapose against the NCI designated in urban centers? I don't know that we're doing that much better in making sure that Black women get the standard of care even where there is the access, unfortunately. And I think that's a study that's worth looking into, and data that we should explore, is that does having the access equal parity in the quality of the care that we get?
right.
It didn't provide that specific data, whether NCI cancer centers are similar. But I would also dare to say, like you, that even there, we're not doing as great a job with all of our patients providing equitable care. There's been little studies that have shown that we're less likely to introduce a clinical trial to a woman based on her skin color, even at these academic medical centers. So totally agree with Dr. Gary.
Now, Dr. Guerra, you lead both research and community engagement, so you are seeing the full picture, if you will. What do the most recent data show about incidence, mortality, and stage at diagnosis for Black women?
Yeah, unfortunately, not much has changed. Your introduction said it best. The American Cancer Society keeps a close eye on these statistics. And as you said, cancer incidence is actually rising in all women. So, we don't even know why. And that's a very troubling statistic for everybody. Cancer incidence, interestingly enough, is slightly lower for Black women. I think it's 131 per 100,000 versus white women, 137 per 100,000. So there's actually more incidence. But you said how mortality is 40% higher, and that's still true. Mortality is declining, however, for both Black and white women, but still Black women have that higher mortality rate. As far as stage of diagnosis, I think it was Dr. Gary who said that women are still being diagnosed at regional and distant stages. Black women have a disproportionate share of those, and less so at localized stages. And what I find really intriguing about that data is when you look at mammography rates, they're actually higher in Black women. So how can they be higher in Black women and we're still diagnosing cancer at later stages? When I've thought about this problem, my only explanation is that mammography maybe is not the most sufficient test for a woman who's Black. And that's possibly because there may be more dense breast tissue in that population. And so should Black women with very dense breasts be getting mammography? Mammography, yes, but should they be also seeking for additional testing like MRI, which is better for
Right.
dense breast tissue.
Yep.
So that data, to me, I need to make sense of that, and that's the only explanation that I've been able to provide, but I would love to hear Ricky or others' opinion. Oh, Ricky, you're on mute.
I would add and say that it's because we're younger. We're not getting mammograms yet.
Yeah.
The data for Black women under the age of 35, twice the rate of white women. We're dying at 3 times the rate of white women. And so we're getting breast cancer before you can get a mammogram, before you know your breasts are dense, and before you're even in the system. So I think we know 40% of triple negative breast cancer patients are under 40.
And Ricky, your point is a good one because the younger we are, the more dense the breasts.
Right.
Right.
So
Right.
even if we got mammograms earlier, it wouldn't
They're not
help.
gonna show.
Exactly.
Right.
Yeah.
Exactly. And then
Yeah.
density decreases with age,
Yeah.
and it's inversely related to BMI. So
Right.
heavier women actually have less dense breasts, and thinner women have higher
Right.
density. So, but it's a great point.
I
Now,
think it also speaks to sort of what happens after screening because, we talk a lot about looking at the screening rate, but from screening comes secondary imaging and diagnostic imaging, and that has a lot to do with the financial toxicity of obtaining
yes.
those things, right? There's absenteeism from work, there's high deductibles, there's copays, there's, the prior auth that's needed for the MRI, and all these things are sort of compounding after you get that initial screen that says we might screen at the same rate, but does that mean that the diagnosis is happening? Are we following through on the next and the next and the next step to get to that diagnosis? And studies show that 1 in 5 women, working women with good insurance, if they have to pay something out of pocket, they're not going to do the diagnostic imaging. And so there's a built-in sort of barrier there that is kind of the silent the gap. It's the dash in between that screen and then what's discovered.
Now, Dr. Guerra, how do social determinants, access, insurance gaps, bias actually translate into the disparities that we're seeing in outcomes?
I think they're very tightly linked to the mortality statistic we talked about, as well as to the stage of diagnosis. If a woman is uninsured or even underinsured, if she's on Medicaid and the cost of screening for her is perhaps covered by Medicaid, but the problem is the diagnostic workup can also be challenging from a copay standpoint and all the other reasons we discussed. I think that one important thing to remember is that there are federally funded and state funded programs to help those women who need those diagnostic workups to cover those costs. And that's through the breast and cervical cancer early detection program that's available to everyone in every state. And so that insurance, I think, is a major factor for some of the statistics we are seeing around survival and access to diagnostic workups.
I would add to that, we work with Dr. Lauren McCullough, who too knows pretty well at Emory. She's a badass doc, sorry, studying the social determinants of health. And she has a study that basically says that Black women who have equal insurance to white women have a 60% higher mortality rate of breast cancer. Black women who live in a high socioeconomic neighborhood have a 126% higher mortality rate than the white women in the same neighborhood. Yeah. So what does that say? So even when the cards are the same on terms of insurance and economics, we're still dying at bigger numbers. So I think we can, and clearly access to care and all these social factors are critical and important, but still we're still dying with their equal.
And that makes you wonder about the quality of care. If you have access,
right?
What is the quality?
What's the quality? Right.
So that takes me to why the Chrysalis Initiative was launched in the first place, because, I was told when I became a patient advocate after being diagnosed, oh, it's social determinants of health. It's due to lack of insurance. It's due to, poverty and et cetera, et cetera. And we see that's not the case. And we still hear that same narrative even now, even though we know that that's not accurate or, actually presented in the outcomes that we're seeing. But Dr. Goyer, what data-driven interventions have demonstrated real effectiveness that health systems should be scaling right now?
Yeah, I think we were just talking about data, the quality of care that we receive, and there are um, commissions that certify cancer centers and accredit cancer centers that we have been advocating for quality metrics, and it's hard to believe that it's 2026. So we've been advocating for years for a single health equity metric in the Commission on Cancer's accreditation process,
Right.
and there isn't one. In fact,
Yeah.
I'm on the committee at Abramson Cancer Center, and when we were reviewed last year, we were reviewed every 3 years. I brought this up, and the reviewer, the site reviewer, was actually quite embarrassed. He said explicitly he didn't know that that was the case, and he was going to bring it back to his leadership. But I think we have to advocate for quality of care for all people, and having a single, even several health equity metrics to accredit these cancer centers might be a start to getting us there. So we
I
need
kind of
to,
feel like it can't be just a checklist, though, right? Because some of the
yes.
most racist health systems now actually would pass a lot of the equity standards as part of that accreditation process. So, meaning to have some accountability and some teeth and some penalty and some consequences, which I see that we had some progress in prior administrations where, it was kind of attached as a carrot in certain funding streams. But now it seems as though we're kind of going backwards. But I do think that that's important where we could kind of implement that, where it's not just a nice to have, but that it's a requirement. Now, Dr. Mo, you are on the front lines every day, and I describe it as front lines because from the work and the patients that we support with the Chrysalis Initiative, surgery and treatment are where we see the most impactful disparities. So what systemic barriers are you seeing impact how Black women navigate diagnosis and treatment?
Ooh, so we talked a bit about barriers, certainly in access, like access to having highly trained individuals, having access to the providers that you need for things like plastic surgery referrals, where we see that there are
Mm,
decreases in just the offering of those. And there's a barrier in access to navigation, right? Because the landscape is increasingly complex and there's more appointments. It's overwhelming, and we end up saying, well, we offer these things, cardio oncology, oncofertility, psycho-oncology, but helping patients to access and navigate through those things, you lose the patient sometimes. And it's easy to say and sit in our style and say, well, we offer these things and we check the box and tumor board. Yep, all the things, right? But did we really help a patient use any of that? Did we really help to navigate those patients through that landscape? So I think that there's a barrier there that can result in just less of a quality experience, but can have implications for, fertility down the line. It can have implications for psychosocial distress and later cardiac dysfunction, right? There's actual physiologic consequence of that. I think there's barriers in innovation and parity, meaning decreased genetic and genomic testing, right? And especially as it pertains to recurrent disease, as it pertains to, metastatic disease. Like there are more biomarkers now that we should be testing for, and we need to be beyond ER, PR, and HER2. And when you start getting beyond those three, it gets a little bit interesting when you start looking at how are we talking to patients about the benefit of biomarker testing, and are we offering those things? And the other thing I think is back to the sort of the social determinants of health. I was fortunate enough to participate with ACCC last year. We did this survey, actually 24, and we published it last year, looking at, how well U.S. oncologists understand the implications of social determinants of health in metastatic breast cancer, right? 75% said that they ask about it, but the majority said they lack the resources to challenge the disparity that those determinants portend. They didn't have anything to offer, so they stopped asking, right? And that's a huge barrier that ends up impacting every aspect of care, because we build in things into our EMR to do these social determinants of, checks and food insecurity and all these things, but having the partnerships and the resources to help, especially Black women, to utilize those, and then tracking those metrics, I think is where we're seeing a lot of those barriers play out.
Can I build on that, Jamil?
Yep.
When you think about the social determinants of health, you think about what is your normal? Patients don't know what that means. Patients don't know what genomic testing means. They come in, and I hate to use the word, Haley hates when I use the words health illiteracy, but because it's not our fault. But the calls we get are, well, do you know what subtype you have? No, what do you mean by that? What does metastatic mean? People just don't know. And why would they? How would you know? How would you know how a clinical trial works? How would you know what triple negative breast cancer means, right? Unless you're in it, right? And so we have this wave of new patients every day. We get new customers in our business every day, right? How many people got diagnosed today, right? So they're coming in with this level of lack of knowledge that they don't know to even ask the questions about genomic testing, to ask the questions about genetic testing. And so I think that's why all of us are here as advocacy groups, because that's what we do. I mean, I think, how many calls did you take today from a new patient saying, help me, I don't know what's going on. I just got diagnosed. My chart. I got my chart today. I haven't even talked to a doctor yet. So we're in this vacuum of information that we have to provide. And so that's where navigation is critical, I think, and that's what you guys do, and that's what we do, but having 24/7 navigators that are Black women who are survivors, who can talk the talk, is really critical in terms of being able to give these people the information they need. But I think our job never ends because we get new patients every day. But I think we're always trying to figure out what's the best way to communicate this. What's the best, explanation? I call them all the time, Mo, give me a food analogy for genomic testing. Give me the farm analogy, right? So I think that we all are striving towards figuring out the best way to talk about this horrible thing. But we're dealing with people every day that are confronting something they've never heard of and they want no part of, And so it's a challenge to make sure that they get the care that they need, but they don't even know what to ask for. So I think, our work is never done. We have to keep doing these God jobs that we have to help people understand. But again, it's like, how do we scale it? Right? Yeah. We can all reach so many women every day, but I had 4 calls like that today, right? Of new people saying, I just got diagnosed. My daughter just got diagnosed. She's 24. Right. What's triple negative breast cancer, right?
What's metastatic mean?
What does metastatic mean, And like, stage 4, that doesn't sound so bad. How many stages are there? Like, God bless you.
I know. So Dr. Mo, if we were designing a patient-centered, culturally confident care model specifically for Black women, what would it include?
Oh, if wishes were fishes, right? Oh man, I love
say
this
we
question.
know that Black women are disrespected and disregarded, and we are creating our own, building what we need, right? If
Right.
we're not waiting anymore.
You
So,
gotta see it so you can be it, right?
right,
And if we keep focusing on the problem and not the solution, we just recreate. You're right. And I
exactly.
say, the umbrella statement, of course, is it would look like centering the patient and not the disease.
Right.
Right. And that is the holy grail. So making sure that from the time of diagnosis that, we've got the individuals who matter to you who are included in conversations, right? That there's ample time for explanations and not just sort of the presentation of materials, but the what do you understand about what's going on question that we don't always like to ask because it can open up a can of misunderstanding that now has to be corrected. But that's the question we should be asking so that we can correct the misunderstanding right where it happens. It looks like making sure that navigational services are provided and clinical trials are emphasized up front and supported rather than waiting for failure of treatment, right? And so I'll tell you what it might not look like. It might not look like Black and brown providers, right? It may not. That is the reality, less than 2%. But it looks like feeling seen and centered
Right.
rather than tolerated. And it would look like offering and not waiting for us to always ask about the resources. Um, and the last thing I'll say is it looks like centering our survival and not just our mortality. And
Mm,
so much of the language around breast cancer in Black women is always in terms of our mortality and never in terms of our survival. And I think that's a fundamental shift in our language. We have to change how we talk about this. And it's not to gloss it over, but it's to reframe it in the setting of what is possible instead of the statistics that are always in the negative for us.
right. And I think that's about, having space for Black women being receptive and acknowledge that we're deserving of care. We're deserving of support, right? Where it's not this, oh, she's so strong, right? And we have to be in suffering. Like, no, actually, we want all the above. It's not just enough to know that these resources are available, but how do they actually reach me? How do they reach the patient? Um, so considering that, Dr. Mo, where are we still falling short in training providers around bias and communication and survivorship needs?
Ooh, well, I think we've said it all, but here's what I think is happening. We're increasingly aware of bias, but not necessarily equipped to intercept it. I think that we are trained to look at it, not how it impacts patient outcomes, more how it impacts patients' feelings, right? There's a lot of conversation around how it made me feel. But the reality is that if we don't offer these things, do patients do poorly? Do they have worse outcomes? Do they have cardiac dysfunction? Do we exacerbate comorbidities through what we do? Do we decrease survival, right? And so there's something on the other side of that we need to tie that to that directly can correlate to the level of our bias that I think would hit home in a really visceral way for healthcare professionals so that it's not just focused on how you made somebody feel, but actually on the clinical impact of it, on the ROI, on the dollars and cents, of that. And that's where a lot of the work I know Chrysalis has been working on is measuring the ROI on or the lack thereof
Right.
on bias, right? Um, and so I think that means we need more collaboration and fewer silos. Because
Mm,
what happens is you realize that you don't have the resources. Like shared decision making is good, but you got to have more than one decision. And what if you don't have those decisions at your center where you're getting, 80%, 70% of women of color get their care maybe in community settings where there aren't a whole lot of options and decisions. And so we really need to look at how we're funneling and utilizing resources and partnerships.
absolutely. So Tia, your work in community advocacy and navigation is transformational. Um, what recurring gaps do you see Black women facing as they move through diagnosis, treatment, and survivorship?
Yeah, I think some of the things that Dr. Mo said, I echo those things that we're repeatedly seeing. And it goes beyond, I think when we look at the medical system, they're treating the tumors, right? But who's treating the instability that actually follows the diagnosis? And we need more of that to happen, right? So not only when they're dealing with, their tumor, their cancer, but also making sure that that instability is being taken care of as well. When we think about Black women and what we're trying to navigate, it's not only just the treatment. We're not trying to only navigate understanding the diagnosis, the side effects, all of those things that come with it. We're also trying to navigate holding on to our jobs, income loss, financial burdens, taking care of our families, because a lot of us do take care of not only just, our children, but you got to think nowadays, a lot of us are caring for our parents, right?
Mm,
Or we're carrying up and down.
right.
So we have a lot as Black women on our shoulders. We're trying to navigate transportation issues, unaddressed trauma, right? Things that are, cancer can be triggering for so many things that we've experienced. And so when we look at that, we're saying we need more support in those areas. We need not only to care for the tumor, but all of the other things that come after. When we think about the social workers, bless their hearts, they're trying to do the best that they can, or at least some are trying to do the best that they can. But when we look at the recommendations that came from AOSW in terms of how many patients should a social worker have at one given time, how many caseloads or that they should be managing at one period of time. It's somewhere around 100 to 150. But that's
More.
not the reality, right?
Right.
That's what they're recommending, but that's
Yeah.
not the reality. I mean, some of these social workers are managing up to 500 caseloads.
Right.
So what happens when the patients have these needs and the hospital systems are not taking care of that? And don't let me get started on 340B, right? But when you think about that, it's like the patients then come to us, right? They come to the community organizations to help in those areas. And so what we really need to have is some type of joint effort where when the patients actually are going to the hospital systems, they're also working with the community organization so we can make sure that the whole person is being treated. Because when you think about this, it actually is showing up in the outcomes, right? It's showing up where patients are, the quality of care, or the patients are missing their appointments and things of that nature. So not only are we seeing those issues, we're also seeing delays in care. That's a huge issue. I mean, even get into a diagnosis. So we may, put a check in a box to do screening, but like we said earlier, get into the diagnostic part, right? I mean, I've gotten in the last month, I would say we've gotten 3 phone calls from women who have had their screening, excited about their screening, and they've gotten callbacks to say, we found something. And now their care is being delayed because we don't have an appointment for a whole month. They have to now wait. And so what is happening to that person while they're waiting to get an official diagnosis, if
Right.
that's what it is, right? Whether it's cancer or something else. That anxiety is through the roof right now. That fear, and that shows up in their jobs, how they care for their families, their children, all of those things. So these are things that we're seeing at a community level that our community really has a need for.
How can health systems better collaborate with community-based organizations to prevent late-stage diagnoses and reduce disparities?
Yeah, so thinking about that, how do we all work together, right? And so we're talking about removing barriers here. And I actually think we're talking about the state of Black women, the state of Black breast cancer. I think that our leaders first need to come together to remove the barriers. The hospital systems are there, but I think we need to come together. We need to strategize. And when we strategize, we can then build infrastructures to negotiate our power. I think about it's Black History Month, right? I think about what our leaders did in the past. They came together, they strategized, and by them coming together, they now have a plan that they can enact and be on one accord. So if our organizations come together, the community-based organizations that focus on breast cancer, if we take this similar approach, we can move mountains. And I think, Dr. Mo, you said it earlier, we're all doing great work, but we're doing it in silos, right? We're competing for some of the same grants. We're serving overlapping neighborhoods. We're doing things in parallel, but we're not coming together. So I think if we come together and align first on things like navigation standards, we can share data with each other, data around delays, because we don't hear enough about the delay of care. We report out on mortality rate, but how many times are we really hearing about the delay of care, right? Or the drop-offs? We don't hear enough about that. But if we can share the data, we can then shift the narrative. And then once we have this in place, then we can go to these healthcare systems in power, right? Standing together in power to say, okay, listen, we have something that we know can work, right? And if we all work together, we can then strengthen the quality of life for our Black women and improve their long-term outcomes.
And where do you see breakdowns in communication or trust between institutions and the community?
Yeah, I mean, it's how, one, let's look at maternal health, right? I'm gonna take it out of breast cancer. If we keep seeing these things over and over and over, when a person gets to a diagnosis, how do you think walking in the door, they're gonna feel? They're gonna be afraid. They're gonna be fearful. And then when we have doctors that are not talking to the patients, but they're talking around the patient, or they're talking, down on a patient, right? Those things don't bring about trust. Or we feel like our voices are not being heard, or we're in the doctor's office and we're only there for 10 minutes. I got to gather myself because I'm very emotional about a diagnosis. But next thing I know, within 5 minutes, the 5 minutes that I have left with you, you're really not making sure that I understand my diagnosis. So these are things that people are seeing, and let's take it beyond breast cancer and the healthcare systems. Look at the racism that's happening today.
Yeah.
All of the stuff that's happening in the media with police brutality and all of this stuff, all of those are continuous triggers for us to say when we get diagnosed and we have to go to hospital systems and deal with the healthcare systems, all of this affects us because we carry all of that with us when we go into, having to sit in front of someone who don't look like us.
Right.
And then, of course, insurance, right? We're dealing with this issue of insurance here in Georgia, where I'm at. We don't have Medicaid expansion. So even we have programs for the breast and cervical cancer, but then what happens when treatment is over and you need that long-term care, that follow-up care? You're no longer in treatment. So
Right.
all of those things affect our trust when it comes to the healthcare systems. And we really have to change that. We really have to have more doctors who are more compassionate, more doctors who are showing that they care about the whole person and not just the cancer, more doctors to make sure, or their team, right? Because the doctors can't do it all, but their team really have understanding. And then we need to go into, these insurance companies because a lot of them are making decisions and that's affecting the hospital systems because they're under
Right.
pressure. They have to meet their numbers. So all of us have to come to the table and work through this. I call it the 7 Ps, right? The patient, the provider, the care partner, like all of us, the policymaker, we all have to come together, pharmaceutical companies, to really make a difference.
Now, Ricky, you've been instrumental in framing Black breast cancer as its own distinct crisis. Why must we treat Black breast cancer as a different disease, and what needs to change in research and funding to reflect that?
A lot. That's a big question. These are really big questions, Jamil. I love them. Well, we're part of Project Sambai. We're so blessed to be working with Dr. Melissa Davis, and she's the first Black woman to ever receive a Cancer Grand Challenge grant of $25 million over 5 years. It's the biggest disparity study that's ever been done in the history of cancer. We're studying breast, prostate, pancreatic in the US, the UK, Ghana, Nigeria, South Africa, Ethiopia, Kenya, and Zambia. And T is part of our team, and we're looking at all these disparities. But I can show you some pictures of cells that I've now seen out of Guy Cancer Center in London, where the cells look different. We're seeing that for all of the cancers, and the data is coming out, and it's real. It is real, and until we accept that data and have pharma recognize the data to say, okay, we need to change how we think about drugs. And so we're spending a lot of time just understanding the science, and we're looking at the social determinants of health. We're looking at the genetics of cancer. We're looking at the genomics of the cancer cells. We're looking at the exposomics. Like we're looking at, everybody in Flint, Michigan is probably going to die in 50 years from the water, right? So what are all these factors and even the emotional factors that are affecting Black cancer? And so, the time is now to recognize that the science is different, and that has to be reflected in everything that we do. So we spend a lot of time recruiting for clinical trials, working with the pharma companies to recruit for clinical trials to get our representation commensurate with the burden of disease. We've been historically, ignored in clinical trial research. And so it's like 3%. So even the drugs that are being made now aren't reflecting our bodies. And so it's critical that we all, as a community, participate in trials. And any research you can participate in is good research. Anything we can learn about Black women is good research. And so we all have to sort of, Black, we got to do all the things. We got to take it on and be a part of it. One of the things that we've been, I always say, I like to go where Black women live, work, play, pray, and slay. They're not going to come to us until they're sick. We have to go and meet people where they are. So we're trying to build communities around doctors. So we have, kind of a list of this 100 PIs that are kind of doing clinical trials in breast cancer. And in each of those cities, we're trying to build a community around them, a local support group, a local organization that may not have a 501c3, but they're doing the work. They're in the community. They're holding heads over a toilet, driving people to chemo, taking care of babies. But so we connect the PIs to the community around them and try to create this union where they can have a source to recruit for trials. And then also the community organizations have an outlet in a hospital, in a doctor's office, where they know they can get help for patients. So we're trying to build these communities all over the US. We're now, we've probably got about 100 of them now, but it's not enough.
Yeah.
I think one of the areas that we're really working on too is using the church as a way to reach patients. How many women go to their pastor before they go to their husband or their partner, right? We did a focus group last night of our new kind of pastoral advisory team, and they were telling us incredible things like I'm going to tell my pastor before I tell my husband or my wife or my kid or my family member, and that pastor better heal me. Like I'm going to count on that. So our campaign is actually called After You Pray, What Do You Say? So we can help pastors have a toolkit that they can use to deal with patients or direct them to resources, direct them to us, direct them to you, direct them to other support groups. So I think it takes a village. As we've all said, this has got to be a collaborative effort, right? We all have to hold hands. Oz is over there in the corner where there's no breast cancer, and we're all on this yellow brick road. But if we're not working collaboratively, we're not going to get to Oz. And I think we all have to, and not only our advocacy groups, but also our doctors. And all of our doctors, most doctors aren't like our Mo, who treats her patients like family, or Dr. Carmen over here. I'm just meeting for the first time. They're in a silo and they're not talking because they're busy. And so, but we have to. So that's why we're saying, hold on, wait a minute, Dr. Vidal in Memphis. Here are all the women you need to be partnering with. Here's people you need to know in the community. And Mo does that with her farm, and I think we have to do more of that, so the doctors feel part of the community that they're in, and not just patient to patient. But it's really, cancer affects the whole family.
Yeah.
It doesn't affect one person. It's a family disease. And so everybody needs to be engaged at some point, and nobody should be fighting this alone. Nobody should be going to this alone. So I think we just have to continue what we sort of do as advocates, but make it bigger than us. So we build communities around doctors, around cancer centers, and provide the care that we need. And the cancer center closed at 5 o'clock. The conversations happen at the dinner table,
Right.
or when they go to bed, or at 4 o'clock in the morning when they get the MyChart report. So that's
Right.
why that's why we do 24/7 care, because, and we get most of the calls not during the day, but at night.
Right.
That will tell you 5 o'clock in the morning her phone's ringing. So I think we have to try to make ourselves available to patients so that we're there for them, because we're all they have. But I think we also have to put some responsibility on these doctors and these oncologists that are doing this work, and make sure they're putting their heart into it, that it's not just science. And in the clinical trial space, patients don't do clinical trials because they want to advance science, because they want, to get the drug approved. They do clinical trials because they want to see a grandbaby being born. I'm having my first grandson in July. That's why I did a clinical trial. I never think I would see grandchildren, right? So they do it because they want to see another birthday. They want to get another hug from somebody they love. So we have to put the love into the science. We have to put the hug around it, but we have to do the science. And we all, as Black women, have to participate. I've done about 12 trials for different stuff beyond just the drug I took. So if there's an opportunity in your cancer center and you want to find one, we'll help you find it. But we need more science, and our cancer is different. I can't say it enough. And hopefully the world will start to see that. I think Melissa's study, the Soundbite study, is going to open a lot of doors in terms of seeing where the differences are. So I'm so blessed that we're part of this. And I just spent a week in Nigeria, and 80% of the cancer in Nigeria is diagnosed at stage 3 and 4. That's outrageous. And it's because of access to care, really because of lack of understanding and cultural beliefs that you're going to die. And we don't have to die. I wish we could make it go away, but we don't have to die. We don't have to have these mortality numbers. We have to have early detection and have the best solutions. So I don't know if I answered your question, but I'll get off my soapbox.
You definitely did, and I have a follow-up for you.
I'm ready.
What policy commitment should be non-negotiable going forward?
What policy commitment?
Right.
Screening. I mean, we have to catch it early. the policies around screening and not just screening, but diagnostic screening.
Right.
So you have to be able to get, and screening at a young age. 40 is too late for Black women.
Right.
It's
10
late.
years prior to any
It's
known diagnosis. Yeah.
It's too late, right? So screening at really, what's the rule that everyone under at 25 should have a risk assessment, right? You should be able to get screened early. And then when you get screened, if you have a funky result, then you should be able to get free diagnostic screening and understand if you have cancer or not without having to worry about how much an MRI costs. If we could
Exactly.
catch the cancers early, we'd be in a different place. We need to be I think we should have policy to support catching cancer early.
I love that because that's the biggest issue where the bureaucracy, most of our patients are being told that
Right.
there's no coverage or they can't get that additional diagnostic testing. But how do you know that you're getting the right treatment if
Right.
you don't?
If you don't have it, you don't have it.
Insane. And actually, the companies cover the cost if in fact it's not covered by insurance, but most of the time it is.
Right. But
So
you should
we're
be able to get the diagnostic test. You should be able to
right,
get genetic testing, genomic testing. You should be able to get all of the testing that you need
right.
as soon as you have a lump, right?
Period.
With no waiting, with no anxiety. I mean, think about that waiting period for when you have to wait, as Tia said earlier, from when you go to get screened and you have to wait for
Right.
doctors to get the MRI.
We've had
What
patients be told you got to wait a month until we call.
I
So,
know, till we call you, right? What is
right.
this? Crazy. So, but also, even once you've had that biopsy, those
Yeah.
3 days are like being in hell,
Yeah. Hmm.
being on fire. And so we need to change even just how the system works so that people can get care. We work with a doctor in Ghana, Dr. Beatrice Adai. She's an incredible surgeon in Kumasi. She has a hospital called the Peace and Love Hospital. She's actually hooked up a system where she sends a biopsy to UCLA from Ghana, and she gets an answer back in 5 minutes whether that whether that biopsy is cancer or not.
Wow.
Now, if she can do that from Ghana, why can't we do that in Atlanta, DC, Chicago, New York?
Yeah.
So she has a relationship with UCLA, and they start as a test. Oh, we'll test this with the little Ghana doctor and see what happens. But she's diagnosing cancers in 5 minutes. So it can be done.
Yeah. And Ricky, where is there the most urgent opportunity to shift investment, clinical trial access, or research priorities?
Ooh, the money needs to be everywhere, and I think that, NIH is failing us right now. The government's failing us, but, I have to give it to our pharma partners. They are stepping up and they are doing all the right things. Thank you, God, for them. I'm so blessed that we all can work with them, and I'm so grateful for what they are doing because I think they have stepped up. They have, stepping up to the plate and putting the resources in place. And actually, we're working with NIH kind of fell out of our Cancer Grand Challenge funding scenario, but CRUK, Cancer Research of the UK, they have stepped up and they are giving us the funding that we need. So I think that, I asked the CEO of Genentech years ago, what do you spend more money on? Doing research to cure the cancer or research to treat the cancer? No one ever really answered my question, but I think that I don't know where that balance should be, right? And I think clearly we're trying to cure it, and we need to focus on metastatic breast cancer, but
Yes.
we don't have enough resources. We never will until we find a cure. And so I think wherever it comes from, it has to happen. I don't know what the priority should be, Jamil. I mean, I think we need to figure out clearly it's got to start with metastatic disease. If we, that's where the urgency is, right? And I think once you sort of get, we had some drugs for metastatic disease, and then now they're approved for early stage. So I think we have to start there. But I think look at the triple negative landscape. When I had triple negative, 14 years ago, I didn't have any options, right? And now we've got options for the first time. For the first time, we have several options, and they're good. They're working. They're good options for us. Now, could they be better for Black people if we were tested? Yeah. Could there be better ones for Black people? Yeah. But still, the first time we actually say we have a landscape to choose from. But then what does that create? That creates anxiety, like which one do I pick? Which way do I go? Which drug do I take? It creates anxiety because patients don't know what those options are. And pharma is just, they struggle to do a good job to speak in a language in words people can spell. So that's why we have to help them as advocates to help, translate this into patient-centric speak. But, the options are there. So bring us more and let us help you figure out how to talk about them.
Absolutely.
That's
So,
our
you know what I'm going to say about that? I always say that we've had this methodology for, I think, about 50 years, where if we just find it early, cut it early, burn it
yeah,
early,
yeah,
you know, that
yeah.
they're not going to become metastatic. But now we understand that metastatic tumors and early stage tumors, they're related, but they're not twins. And so the more that we can understand about what are the targets and how we can control, we can turn this into something chronic. Maybe not cured, but livable, like
But
HIV or diabetes.
we don't know how many women are like you, Jamil. How many people have de novo diagnosis,
Right,
right? So, and how many Black women have a de novo diagnosis? No one can sort of tell us those numbers. But
right.
what do you do then? Where'd that
Yeah.
come from? How'd that happen?
Absolutely.
So more science, we need more science.
Absolutely. So, Bobby, you work closely with patients navigating a system not built for them, and you were the first coach I hired when I launched the Chrysalis Initiative. What are the most persistent challenges Black patients experience in advocating for themselves?
Pretty much everything that was mentioned by everyone still. And it's worse now because of the administration
Yeah.
with regards to medical insurance. So a lot of it with the women that I coach now, a lot of it is that a lot of the doctors do not listen to them. Too many of them do not park their biases at the door. Uh, Also, they don't talk to them about clinical trials. There are times where they leave out certain things with regards to standard of care. I think what the Chrysalis is doing is just not a one and done. We actually walk with our women through and through, even when they get to survivorship. And once they get to survivorship, sometimes they feel like, what am I supposed to do? Because some places do not give them survivorship care plans, but that's where we come in and we help them. And there are some ladies right now to this day, 6 years later, I'm still there for them. They can call me day and night. I'm on vacation. I will answer their calls because the truth of the
24/7,
matter, yeah,
24/7.
because the truth of the matter, I do not want to be somewhere and not answer somebody call because they may be going through something and God forbid something happens. I don't want that on my conscience. So that's what I do. That's how I do. Just not the delays in the surgery treatment, not explaining genetic testing, genomic testing. Um, there's a lot. There is a lot. And the fact that, just what Ricky was saying about 14 years ago, but for me, 12 years ago, triple negative was a big thing, and metastatic breast cancer, right? And the death of Black women was still 40% 12 and a half years ago. Why are we still talking about this now? And these are the things that I ask my medical people, make it make sense.
Yeah.
So, Bobby, which parts of the patient care pathway still lack lived experience informed solutions?
Uh, it would be one, palliative care for one, different resources. A lot of them are not getting the resources that's out there that can benefit them. Um, Still clinical trials. Uh, the sheer decision making. Too many doctors are telling women what they want to do with their bodies, and I'm like, no, that's not going to happen. So is that? So I think a lot of it is resources. There are a lot of resources that's out there that's available to our women, but they can't get it because some places just don't share it with them until I say something, and they're like, well, my doctor didn't say this, that, or the other. And I'm like, well, it's available. You can use it. But more importantly, I think we need to also think about once they get to as we call it, the 5-year survivorship. We really need to focus and help them do that because too many women are falling through the cracks with that. Because you got to deal with, like we said earlier, everybody is taking care of everybody besides themselves. And then just the resources that's not available to them. And we can't do it all. We try to do as much as we can, but they're falling through the cracks, even through survivorship. So we got to figure out a plan how to survive, or as we like to say, find our new normal.
And Bobby, what are actionable ways institutions can integrate patient voices into decision making and program design?
um, Pretty reaching out to patient advocate organizations, even those who are not part of a patient advocate organization, just reaching out to those who are doing the grassroots, doing the work in the community. So we could, do it that way. Also, I just really believe we have to get to people before they get sick. I really believe that. And until we do that, we're going to keep running into the same problem that we're having. So for me, it's like a vicious cycle. And, like I said, I'm 12 and a half years out and we're still talking about the very same thing. So obviously something we have to do something. I don't know exactly what it is, but I will continue to do my part. I sit on different places where we talk about the clinical design, and I make certain if I'm talking about this clinical design that's going to help people, I make sure that organization, when they put the clinical trials out there, that they're making certain that they put Black people in it, especially Black women.
So to bring it all together, this question is for the entire panel. How do we ensure Black women are not only represented in research, but truly centered from the start, like Dr. Mo said?
All of the above.
Mm.
Well, I think too, it should become a requirement, right? So if you're going to get funding, you have to have a patient advocate at the table. You have to have a CBO at the table before you get IRB approval, before you get anything, you have to have us at the table because that's the only way. We have to force it and not just lean on it and expect it to happen. So I think if we put some of those things in place, it will help to ensure that we are at the table and that we're a part of a part of the process, right? Where we're developing for us, it's kind of for us by us, right? So we're a part of the conversation and not an afterthought. Too many times researchers have come to all of us, and it's an afterthought, and you're like, wait a minute, you can't do this. Wait a minute, this is
Yeah.
wrong.
Yeah.
This is not going to work. And so we're trying to help them, patch up something that I'm not going to call it broken, but patch up something that if we want to say broken, we can call it broken. But if there's a way that these funders can say, no, you make it mandated that we're a part of the conversation. Because that's the only way we're going to change it. Back to what Bobby said, 10 years for me, 12 years for her, Ricky, 14 years or more. It's like nothing has changed. Even, I was at a conference last week and they were talking about Georgia. They said nothing has changed for mortality in 20 years. So all the monies that we're raising, all the funds that are being poured into research, why is it not changing? And why aren't we asking those questions before we give those dollars?
Well, you know what I would say. I think people are comfortable with the status quo, but I digress. Um,
But
Now you talking. I think we fund the safe ideas, right? We
yeah.
do. We stick to the mainstream and
we've
that
actually been told that this is too far from the status quo.
Yeah.
So yeah, we're not going to
Well,
fund that.
well,
Too radical,
my hashtag do iconic shit back here.
right?
We cannot do the status quo. We cannot
Right.
afford it. But that's why I believe the power is within us as Black women. And that's why we spend so much time educating patients, because we're going to have to make the ask. The system is not going to change until one by one, we make the ask, we push the envelope, we demand the care, we fight for each other, whether it's our sister or whatever, our patient. But that's why we have to educate ourselves and educate ourselves before we're sick, Roberta, before we're sick, before your mother gets it, or we also have to teach our families to know our family histories. So many of these cancers are connected. BRCA with prostate, whatever, I mean, and our dad had prostate, now we got triple negative. So I think we have to educate our families to talk to each other. I met a family a few years ago at a share conference where the daughter was 37, stage 3 triple negative. It wasn't until she got sick that her mother and her mother's sister, her aunt, told each other they had triple negative in the last 2 years. Crazy. So I think we have to continue to educate, and equip our women, not only with the knowledge they need to have, but also the balls to say, wait a minute, doctor, you're fired because you didn't give me XYZ,
Right.
or demanding the care that we deserve. And so I think we have to, but we have to do it in ways. I mean, even, when I talk about clinical trials now, I talk about ice cream. So, because people don't understand what standard of care is, right? So what's standard of care? Standard of care, you get the chocolate, the ice cream, the chocolate syrup, the whipped cream, and the nuts. In a clinical trial, you get the ice cream, the chocolate syrup, the whipped cream, the nuts, and a cherry on top. Who doesn't want the cherry on top? And when you break the science down into words people can spell, into concepts they can grasp easily, they're like, sign me up, let's go. So I think we all have to do the work to help people understand and be equipped with what they need to know. Mm-hmm. And also challenge the system. The protocol about, I tell everybody, do all the things, get the surgery, do the drugs, do the radiation, do all the things. Even all the above. All of them when they tell you not to, because, the research on the concept of get a lumpectomy and radiation, right? And that's the same as a mastectomy. That study was done in Sweden. How many black women were in that study, right? So we know that we have to make the assumption that the data is not in your favor. So the fact that the doctor's telling you this is the standard of care, don't trust it. Don't take it. Challenge it and say, wait a minute, what else can I do? What else can I take? And do the work. Faith without works is dead. Have your faith, but do the work and do all the things and demand all the care. But you got to do that with knowledge. And so that's why, we all go to bed every night thinking, who didn't I talk to today? Because there's always that other person that needs to know. Bobby knows what that feels like. So we have to, and Tia knows what that feels like. We have to just stay out there in the community and make sure our women take the balls and put the ball's in my court. I need to just be the CEO of my own health. I need to be the CEO directing my care. These doctors in the system works for me. And if it's not working in this corner, I'm going to go over here and find another place.
Yeah, Ricky, I want to add to what you're saying. I think we also need to push against those systems that's also creating things, the cancer causing issues, right? So whether it's the food, whether it's the hair care products,
right.
All of those things, we need to push against those too. So if we're saying we really want to get to people before a diagnosis to even help lower their risk, or some people may say prevention, but we need to attack those systems that are building things like environmental pollutions that we're having in our community, right? We need to go after those companies and organizations as well, so that we can be healthier in our communities.
Right. And
some of this is not, some of this is not on us, right? Because of the places that we live, or the foods that they're feeding us, or the products that they're giving us. We are supposed to, we want to trust our systems, right? And they're creating products that we can use that are not affecting our health. But unfortunately, that's not the case. I mean, Tuesday, we're doing with Consumer Reports, we're doing a big talk on, the braiding hair, right?
Yes,
we're doing a recording on braiding hair. Yeah. So these are things, more conversations need to happen around this and bring in more awareness. But the more that we push back on these systems, even the stores, like these beauty supply stores is coming into our community. The fast foods, they keep coming into our communities and they're not bringing healthy foods. We've got to fight against those things as well.
Yeah,
but that's also
piggyback on that. Yeah. And I'm going to agree with you in that, harm reduction starts with not only calling out those systems and those structural things that are in place, but by reimagining, right, what healthy lifestyles look like and educating around that. Because I can't tell you the number of people who think, you know what, I go to Wendy's and I get that salad, and I put two dressings on it, and that's healthy because I ate salad today, right? Or I got a family, I have personally a family full of diabetics. I drink my orange juice every morning because I want my vitamin C, right? Not looking at the amount of sugar that's in that orange juice every morning that we're drinking. And so our understanding of what healthy lifestyle looks like, you know, and this is a lot of work we do at the farm, is really trying to educate around risk reduction, risk reducing strategies that have to start younger, because we are seeing younger and younger incidents of cancer that related to lifestyle, related to sedentary, related to smoking, related to, you know, our ultra processed foods, right? So there's some areas that we can start. We might not be able to, you know, weed out all the microplastics, right? And get rid of every spatula in the house, but we can start. We can start somewhere.
Right,
Absolutely.
but it also affects, women like me who have metastatic breast cancer. How can I keep it at bay with exercise and
Right.
avoiding
Right.
microplastics in my diet and, trying to avoid, products with a lot of toxicity in it with carcinogens and all of that. So I think it's not just prevention, but control.
Yeah,
Yes.
because some of these things that we're being exposed to, even on chemotherapy drugs
Right.
or any of our
Right.
other medications that we're taking, it is
Right.
affecting the efficacy of those drugs.
Right.
We don't even know it. Studies are
Right.
showing it. So,
Right. Right.
that's something that we really need to continue to bring to light and push back on.
Yeah. Again, be the CEO of your own health.
Yeah.
Be the CEO of your family's health. Take it to heart. Do the right thing for yourself and your kids and your family. And know your family. Know your her story. You know. We have a great tool on our Love of My Girls website. Know your her story. It's a worksheet. You can download it, and it helps you sit down with both of your grandmothers who may be resistant to talk about it, but force the conversations on the holidays. Easter is coming, Lent's coming. Sit down with people at dinner table and say, you know, this year our family reunion is going to be about making a health family tree. And force the conversations, because that is risk aversion.
Ricky, I want to touch upon Jamil asked a question about research, and research has its place. It's necessary. But at some point, how many times are we going to research the same thing? Where is the action? And I think we get frustrated because we're like, we don't want to keep researching the same thing over and over and over. And there's no action. Nothing, it's not changing.
Hmm.
Well, it's because we're not acting on the research for Black people. We're not looking at the factors that make our cancers different. We're not focusing on the Black people. That's the relevant thing for us. So the research, if it's happening, it's not including us.
Yeah, it
And
goes back
even
to
when
what
it
I
does,
said earlier.
even when it does, it only points to the disparity. And this is what gets me to it,
Right.
because you're right. You're coming right down my alley here. If I read another article that says more data is needed to support the hypothesis that Black women XYZ,
Yeah.
right? Like, how many times and how many ways are we going to frame the same problem or create and generate data that shows the fact that racism is very real, right? Like, I think it's Toni Morrison said, the very real function of racism is to keep people asking the same question and to keep trying to prove that it doesn't exist when it clearly does.
Yeah.
And so, where's the action plan from this? And I think this is something for our ECOG and, some of our SWOG and some of these working groups, is to really put together the action plan, right? That's based upon the research and the data that we have generated. And, this whole concept of waiting for something, like, where's the threshold? Where is the tipping point? And I'll give you a great example, because I always get sort of uninvited to the cookout when I talk about BEXA, but I mean, we are tired of waiting for guidelines to catch up. In U.S. preventive tax, there's insufficient evidence to say that Black women should screen earlier, that, there's supplemental imaging with dense breasts. And while we are yet working toward getting in the NCCN guidelines, we're still doing what we need to do because young Black women are dying, right? And being told that they don't have breast masses that they know they have, or that they don't meet criteria for imaging when they should have a technology assisted breast exam. So, like, this concept of moving forward anyway, while we're yet working through these guidelines and through these channels, like, we have to do something. We got to move. And not just continue to wait for whatever that point is where everybody says it's socially acceptable enough, or there's enough, groundswell, or enough of us who all believe in whatever it is. It's not like Christmas. Like, this is, we don't have to believe in it to see the data that says that we need to move and do something and take action.
Well, that's why I think the soundbite study is so important, because it's all about Black people. And we are recruiting right now. If you want to give a blood draw, it's a little blood draw. I'll put the website in the chat. We're going to take, if you're in New York, Atlanta, or the DC area, Baltimore area, go on our website or call me and we'll get you involved in the study, but be a part of real stuff that's happening now for us, by us, with us.
Yeah, and Ricky, I'm going to add the voices of Black women. The work that Dr. McCullough is doing with the American Cancer Society.
Yeah.
So,
Right now.
these things are so important. I'll post something in the chat as well. But this is important. We got to get involved and participate in those things that are for us, by us, but also, take action. So we have to prioritize us. Black women have to prioritize Black women.
I absolutely agree.
And last, I'll say, sorry.
No,
I just want to say really quickly, we have seen like this, the only good thing that's come out of, not the only good thing, but one good thing, important thing that has come out of this administration right now is that, the institutions, we've seen like a fading away of performative allyship, right? Because it's been disincentivized at the federal level to, equity and inclusion. So the ones who were going to run, ran, right? And we need to move accordingly. And I think that we have been shown, because it hasn't held up in court, but we have been shown who's willing to actually do this work versus who was just showing up to get the funding or do the whatever, or, take a knee on all these things. And I think that it's important for us to recognize who the allies are, who are the people in it to do the work, and make sure that our partnerships reflect that as well.
And before we go, instead of saying allies, how about saying accomplices? We need people to tear this crap down, period.
And I did not get to all of my questions, but I know that this is a robust conversation. We have to keep the conversation going and keep the work going and think about how do we align all of our efforts for sustained national impacts? How do we make sure that collaboration is authentic? And what does that look like between systems, researchers, pharma, and community advocates like ourselves? And I also wanted to introduce Marissa Thomas, who is the co-founder of For the Breast of Us. I think we only have time for one question that was in the Q&A, but Marissa, could you ask the question of the panel?
Sure, there was one really good question. Hello, everybody, by the way. So someone asked the question in the chat that said, how do we get these hospital systems to invest in advocates of color within our communities? Which I think is a great question.
Panel. Well, I know for me, I find that it's the competition. If they find that it's going to impact their branding to be, of course, during, after the aftermath of George Floyd's death and diversity, equity, inclusion, I think that people thought it was, non-negotiable to not be involved. And I think we can still kind of shame people, I feel like there's power in our dollars, to make sure that, okay, if you want that support, if you want, us as part of that patient population in that alignment with us, that we're not going to go to you if you don't prioritize us and even acknowledge that our humanness, our existence, to prioritize our care. So I do think sometimes it's shaming people, maybe just with our dollars. We're not going to invest in, and it can't just be, okay, you're the only resource available, within a particular area. But sometimes we speak with, our funds because we are a very powerful spending group.
Mm-hmm. I would say that's great, but you know what? I can't wait for the system to do the right thing. We're sick now. We got people diagnosed now. That's why I think Jamil and Bobby do what they do. That's what I do. That's why my Val does what she does. And frankly, even when the hospital has a navigation team in place, they're never going to be as good as us. Sorry. They're never going to be as relevant as us. And so that's why I keep trying to sell our services as Black navigators who are survivors, who are doing this work 24/7. And I'm not going to wait for the hospitals to respond. I think there's too many other issues they're dealing with, and trying to stay financially, whatever, sound. I think that's why we as advocacy groups and support groups have to do this work. And frankly, we're going to do it better because we're going to find the angle. We're going to find the resource. We're going to find the thing that the hospital navigator's never going to even look for. So I think we have to, that's why we're here.
Yeah, and I think that's all the time that we have, but thank you to our extraordinary panel for your leadership and vision, and thank you to everyone joining us. I also want to say thank you to our Cancer Center partners streaming this at their breast cancer retreats and showing this webinar to their patients. And I'd like to also say thank you to our sponsors who are still prioritizing equity in cancer care despite others trying to put it in the rearview mirror. Daiichi Sankyo, Lilly, Gilead, Princeton 10, Merck, Genentech, Pfizer, Novartis, and Exact Sciences. The truth is breast cancer disparities are not inevitable. They are the result of choices, and we have the power to make different choices. And I believe that we should all commit to ensuring that Black women are seen, heard, supported, and treated with the excellence that we deserve. And the work starts now, and it continues with each of us.
Take care. Bless you, love.
Thank you.
Thank you for putting this together, Jamil. Thank you for an impactful conversation. This was
Absolutely. We're going to keep it
truly
going.
wonderful. We should do a watch party and then we can do live questions in the chat again too, because this was great.
And actually, we could do some more Instagram lives, you know, because I always get those requests.
Yeah, let's do it.
Yes.
Yeah.
Everybody be blessed.